I have the honor of holding the Mildred and Claude Pepper Eminent Scholar Chair in Social Gerontology.
Good morning, Yolanda Rodriguez with AARP.
Good morning, I'm Linda Levin. I'm the president of the Florida Association of Area Agencies on Aging and Aging and Disability Resource Centers.
Good morning. I'm Bentley Lipscomb, and I'm one of the people for which this committee exists.
Morning. I'm Ken Brummelsmith. I'm the chair of the Department of Geriatrics and the Charlotte Edwards McGuire Professor. And I'm very happy to be working with Senator Nelson and Kim Lipsky on the Senate Committee on Aging as part of my Health and Aging Policy Fellowship this year.
Good morning. I'm Jay Fogarty, Dean of the College of Medicine here at Florida State University.
I'm David Rasmussen, Dean of the College of Social Sciences and Public Policy.
Good morning, I'm Kim Lipsky. I'm Senator Nelson's staff director on the Committee on Aging.
John Reynolds, I'm the director of the Pepper Institute on Aging and Public Policy.
Good morning, my name is Mary Hodges and I'm with the Florida Department of Elder Affairs here in Tallahassee.
I'm Margaret Lynn Duggar and I work in the field of aging in Florida.
I'm Dan Perry. I'm president and CEO of the Alliance for Aging Research, a not-for-profit group that Senator Pepper helped set into orbit more than 25 years ago in Washington. Good to see you, Senator.
Good morning, I'm Tom Spilek, and I'm the chairman of the Claude Pepper Foundation.
Let me just mention briefly some folks who have been really instrumental in putting this together, organizing it so effectively. One is Paula Moyer, who's Chief of Staff for University Relations. Thank you, Paula. Lynn Bannister from the Senator's office here in Tallahassee. And Monica Laughlin, our office manager in the Pepper Center, have all been wonderful. We also appreciate the fact that President Barron was here this morning. And I also want to recognize Tom Herndon, who is here. He is the Chief Financial Officer of the Claude Pepper Foundation and has been involved with the center and the foundation now for several years. And finally, thank you, Senator, for giving us this opportunity to host the first roundtable that you're organizing since becoming chair of the committee. We're really pleased because we think it recognizes and connects with the legacy of Senator Pepper, very appropriately, given the priority he placed on aging issues throughout his career, and especially the last 10 years he was serving in the House. So thank you very much.
Let me also introduce Pete Mitchell, a Tallahassee resident who commutes every week to Washington as our Chief of Staff. You've already been introduced to Lynn Bannister, who is in the Tallahassee office and represents me throughout this part of Florida. I would like to know who's in the audience, so could you all stand and introduce yourselves? I would appreciate it.
Yes, I'm Lou Marie Polifka West, and I'm the sister of Larry Polifka, and I represent nursing homes, so I'm not at the table today. That was a joke.
That's not why she's not at the table.
Hi, I'm Maddie Vedessa. I'm a student in the College of Social Sciences and Public Policy and also a previous intern for Senator Nelson's Tallahassee office.
Hi, my name is Lauren Swan. I am an intern for Senator Nelson at his Tallahassee office, and I am a senior at Florida State.
Hello, good morning. My name is Brittany White. I'm a senior at Florida A&M University, and I was an intern for summer 2012 for Senator Nelson.
Hi, my name is Cooper Bear. I'm an intern right now, actually, at Senator Bill Nelson's Tallahassee office, and I'm a freshman here at FSU.
Hi, I'm Amber. I was an intern for Senator Nelson this fall in his Tallahassee office.
Good morning. I'm John Mayo. I'm a professor of the College of Social Sciences and Public Policy, and here primarily as an interested citizen.
Hi, my name is Lisa Rill. I do research here with Larry.
I'm Glenn Mitchell. I direct the Claude Pepper Data Center here at Claude Pepper Center.
I'm Jessica Plank. I'm a graduate student at the College of Human Sciences, and I work here at the Claude Pepper Center.
I'm Monica Laughlin. I'm with the Claude Pepper Center.
I'm Tom Herndon with the Claude Pepper Foundation.
Hi, I'm
Libby. I'm a former intern and I'm a 1L at FSU Law.
I'm Billy Francis. I'm the director of the Florida State University Student Veterans Center.
Melvin Stone, director of the Tallahassee Fire Academy.
I'm Ryan Avenia. I work for University Relations.
Good morning, all. I'm Paula Warrior. I'm with the University Relations. Welcome to FSU.
And I'm Lynn Bannister. I'm the driver of Bill Nelson.
Steve Mitchell, I'm just sitting in that seat.
John Daly, Leon County Commission. Andy Harrison, Commission 8 for Commissioner Daly.
Okay, and welcome to the Tallahassee Press. I had the privilege of serving with Claude in the dedication of this center years ago. I had the privilege of sharing some of the stories that I would just go and sit at the knee of Claude and just try to absorb this walking American history book. And I'm so glad that you have this center, and I just can't wait to walk around and see all these exhibits. I think it's also interesting that Claude, he really got his notoriety as a fixture in American politics, not necessarily because of his service in the Senate, but because of his service in the House, which he was able to do when Florida reapportioned more along one man, one vote, and therefore Miami got a congressional district. And when I went to the House in 1978, you can imagine the quality that we had. Just from Dade County, you had Claude, Danny Fasell, and Bill Lehman. And then as you look through Don Fuqua from this congressional district, Charlie Bennett from Jacksonville, Bill Chappell from Ocala, Sam Gibbons from Tampa, some substantial heavyweights. And I had the privilege of sitting at their knee and learning. I think it's also instructive that Claude became, of course you know that he was on the cover of Time twice, once as senator and then again as the Aging Committee chairman. And he wrestled with, by the time he got enough seniority to be the chairman of the Rules Committee, which Tom Spulak was the staff director, he wrestled with whether or not he ought to give up the Aging Committee. And my advice to him was, you can do everything that you did on the Aging Committee as chairman of the Rules Committee, and even more. And so that was very special. I think it's also interesting that in the Senate Aging Committee, I am now one of 3 Floridians who have chaired that. When it was initially set up, George Smathers was the chairman. And then later, Lawton Childs was the chairman. So what Kim Lipsky, our staff director, and I want to do, we want to really kick this committee into high gear. We have a great ranking Republican, Susan Collins from Maine, and she is of like mind. And we are going to be quite aggressive in a hearing schedule. And we're going to be quite aggressive in taking on some examples of fraud that are fleecing senior citizens. and trying to draw attention to that, be it Medicare fraud, be it stealing of people's identity, and how that bedevils seniors. And the substantive hearings that we have, then we will relate with the committees of substance where they have the jurisdiction on legislation. I happen to be on the Finance Committee, which has so much of the jurisdiction on the subjects that are affecting seniors, and the Commerce Committee, and so forth and so on. So we're really looking forward to this. So Larry, let me just stop right there. I want to hear from you all. And so you directed whoever you would like to start.
Thank you, Senator, and I really appreciate that background, that history and that connection with Senator Pepper. I'll go ahead and raise one of the issues that I've talked to you about before and had the opportunity to talk about with the Aging Committee in November of 11 in a meeting that you chaired and requested me my participation, and that relates to assisted living in Florida and with implications for the rest of the country. I was appointed chair by the Governor Scott, of an assisted living work group to deal with some regulatory issues that emerged as part of a newspaper series in the spring and summer of 2011. The committee worked from then and actually did not finish until November of 2012, just 3 or 4 months ago. But as I mentioned in that presentation in November of 11, we have completed a report. Both phases of the report from 11 and 12 contain about 125 recommendations regarding possible regulatory changes in assisted living in Florida. They range from things concerning the qualifications for ALF administrators, enhanced enforcement procedures, enhanced penalties, and also the suggestion that the state begin to move towards a more comprehensive model of consultation with rigorous regulation based on a couple of states that have made major qualitative changes in the way they regulate assisted living over the last 5 years. And in my judgment, based on the information I've seen, including evaluation reports, they've been very effective. I think that this experience actually can possibly serve as a model for some national attention in terms of what we do in assisted living, because assisted living has been the most rapidly growing part of our long-term care system for 20 years. And if you look down the road, it will continue to be for the next 20 years. As a matter of fact, I think assisted living will overtake nursing homes sometime in the next 10 years in terms of the number of people living there. So this is going to be an issue for as far as the eye can see. I really appreciate the fact that you have been attending to it through the committee for the last 1.5 years. And I think some of the things that we've come up with here in Florida may be of interest to you as you think about a national agenda. Now, why don't we go ahead and open it up to others who have issues that you want to bring to the Senator's attention, and maybe we can have exchanges here within the committee regarding those.
Well, right on that issue of assisted living, let me ask you, the Miami Herald did a series on all of what's wrong with the existing assisted living in Florida. I'd love to have your comments on that. And to what degree, separate question, do you see that assisted living becomes a substitute for nursing homes of trying to bring about a better quality of life, but also becomes cheaper for the federal government through Medicare and Medicaid?
Senator, those are right on point concerns. As I said to a Florida legislative committee in 2011, one of my concerns as someone who has looked at this issue for over 20 years is that we avoid having assisted living become an underfunded, underregulated version of nursing homes as we try to contain costs in long-term care over the next 20 years. And there's going to be a lot of pressure to do that because the need for long-term care is set to double in 20 years with the growth of the over 80 population. We've never experienced that before. It's unprecedented. So there's going to be a lot of cost concern. And one of the results may be this pressure to move people increasingly into assisted living, even though, at least according to current definitions, they're not appropriate placements because of impairment levels. We need to avoid that. We gain nothing by pushing people who need the level of nursing home care that we have into places where they will not get it, will not receive it. You may save some money in the short term. In the long term, it's going to cost you a lot more. I think that assisted living in Florida has been fundamentally a success over the last 20 years. When I was director of the state agency, and you've got a couple of other folks here, Margaret Landon Bentley, who've been in that role too, 20 years ago, one of the things I had as high priority was to make it possible for people to age in place in assisted living. And we changed the regulations accordingly and created something called the Extended Congregate Care License. So I'm not someone who feels as if assisted living should only be restricted to people who do not have high-level needs. On the other hand, I think we need to be very careful, and this is responsive to what you've just described as our dilemma. We need to be very careful that as we move people in those facilities, we don't fundamentally change the character of assisted living and also put people increasingly at risk who need higher levels of care. Our regulatory perspective needs to be shaped by that concern. And my judgment is, based on the work of the work group, based on what a number of legislators have been doing over the last 2 years, that there are a lot of people in the state who share that perspective. They value assisted living. They recognize its great success in large measure. But if you're going to maintain that success and the role that we have to have assisted living play over the next 20 years, you can't allow it to go off the deep end from a regulatory perspective and lose the trust of the public as some place where people can live or send their relatives and expect that they will be treated well. So it's a balancing act. You want to build on the strengths of assisted living without, suffocating its role, but not have it become an underfunded, underregulated nursing home program, and that's what we're trying to do. And I know that you're concerned. You just articulated it perfectly, I think.
I did a study with some of my students and colleagues where we interviewed 600 residents of assisted living facilities all over the state of Florida, from the Panhandle to the Miami area, and we found that there were some very high quality nursing, assisted living facilities that did not look fancy, that didn't have chandeliers or screening rooms, but that were very homey and where people received very good care. And I think that the biggest issue is that in some areas there are few or none that take Medicaid. So people that can afford to pay for the full price have excellent choices in an area, but other people who are Medicaid eligible might move into assisted living facility where they can't be near their family, and they have to, I don't believe there used to be one in Tallahassee. I'm not even sure if there's even one that takes Medicaid residents now. There was one that closed while we were doing the study, and then the people had to go all over. Some went to Jacksonville, some went to Carabel. So I think that issue of allowing people to age in place in assisted living near family members is a really important one.
Is that problem that you're describing where the family would pay a set amount and that amount was then utilized to take care of them? It was almost like an insurance policy that they would buy, and Pete Mitchell and I used to regulate those in the Department of Insurance, and we had a number of them that went bust.
Yeah, most of the people that we interviewed were private paid, where they fully paid the amount themselves, where they had a pension and they had Social Security and they were paying on their own. The people with the Medicaid, that were Medicaid eligible, the facility, most of them were less than $2,000 a month for a private resident, and They would give over their Social Security check, which was typically $1,000 a month or $1,100 a month, and then the Medicaid would pay the rest. And so we've actually interviewed very few people that have private long-term care insurance policies, and I know from talking to some insurance people in the area that there have been some real problems with those policies, that people think they're covered and then they find that they're, when you buy a policy in your 50s, which is when they're cheapest, and then you don't need it till your 80s, a lot of things can go wrong along the way, and some of those companies have been sold to other companies, and they buy the policies and then raise the rates. So I think that's a really big issue. There's lots of concern about how the private long-term care insurance industry is treating the people that when they need the benefits.
So, Senator, I think that's kind of building on what you just said, and this has been a surprise to me over the last several months, to learn how many people in assisted living now are publicly supported. When I was first working on this issue 20 years ago, we had a small, then what was called ACLF program. We didn't have much Medicaid involvement at all, but through the expansion of Medicaid waivers, and both that fund assisted living directly or indirectly through other waiver sources, it looks as if we've got over 20,000, maybe 22,000 people in assisted living in Florida who are publicly supported out of a total population of about 80,000. This is growing, and as we move towards long-term care reform in Florida, as proposed in the waiver approved by CMS recently, that population has to grow, inevitably. So this issue is going to become increasingly important as a public policy matter because of all the public money that's going into it.
I had another thing
Yes,
about
sir.
assisted living. I think the balance you talked about, Larry, is very important because as more people move from nursing homes to assisted living, we're going to move a population of people with many more chronic illnesses and more medical problems into a setting that is not used to dealing with that at all. And so, gets into workforce issues. What access do they have to quality medical care? There's no standards in assisted living for medical care. There's limited standards regarding their nursing care. And if people are going to be aging in place, then proper medical care is going to be the thing that prevents unnecessary hospitalizations, which impacts on Medicare expenses. So we really need to look at, how do you balance these people's growing medical needs with the goal of maintaining a home-like environment and not becoming medicalized like many nursing homes are.
Bentley.
Senator, one of the things that we're talking about indirectly so far around the table is there's no long-term care model that's universally agreed on in the United States. It varies across all 50 states. If you went to Montana, you'd have something totally different than you've got here in Florida. And so if the dean of the medical school, who is here with us today, we know what he's going to have in acute care medicine in his medical school because the AMA agrees to that and the medical profession agrees to that, and it all works. When you cross the line from acute care into long-term care, that doesn't exist. And so it is beginning to cause lots and lots of difficulty for us in how we operationalize long-term care because there's no universally accepted model that people move toward. You ask, is it a substitute? It shouldn't be looked at as a substitute. It should be looked at as a part of the continuum, and people should be placed in these different parts of the continuum as is appropriate for the level of care that they need. We shouldn't be just looking at, is it cheaper? Because from being in Washington and trying to deal with what's going on, sometimes what's cheaper doesn't turn out to be that way in the final analysis. It winds up costing a whole lot more. Not to mention the wear and tear on the people who are caught up in the process and who I'm sure are going to be calling Kim and asking why you're doing certain things. So I don't know. I can't sit here this morning and tell you what the answer to that is, but I can say that is certainly a legitimate focus for this committee to take a look at. Because the other thing that's going to start happening manifoldly next year is the Affordable Care Act, which is going to have considerable impact on older people. They don't understand that. They don't understand all the pieces that are involved in that. They don't understand what they're supposed to be doing. The practitioners who take care of them don't understand that. So, and the Senate offices are going to be deluged with requests from people saying, how do I cope with this? What am I supposed to do? And the logical people to be able to answer that question would be you and your staff, furnishing them with information that they in turn can pass on to the people that are doing it. How you get everybody to agree what's going to go into that advice is a task that I don't envy you, because there is a great difference of opinion in a lot of areas. In terms of the personnel requirements in the long-term care arena, in the papers in Florida over the last 30 days, we've seen a lot of discussion of geriatric nurse practitioners, of physician's assistants, of who can do what needs to be licensed how. And you can't answer that question if you don't understand the arena in which they're going to operate, and that's what we're talking about defining. So it's a very fluid situation that you have inherited here in terms of saying, how do we move forward?
Just before I forget it, I want to tell you there's as we speak, a study being done of 1,600 senior citizens, study being done by 8 universities all across the country, that they take half of them as a control group and the other half, and they're trying to determine what really affects quality of life and ability to function for seniors. For example, exercise. To what degree does that really help them? Certain things like aspirin. What's the ultimate result of that? Is it helpful? Is it harmful? And this study should report nationally at the end of this year. So there again, as we focus on aging in America, we're going to have more data that hopefully ought to help us. Now the question is that we're discussing, and we just started with one, ALFs. What's the mechanism, the structure, given the resources that are available in the public sector? What is the structure that you can best adapt to this phenomenon of aging? Further ideas? Yes, Mr. Dean.
Yes, sir. Thank you. To maybe put an exclamation point from a medical training view of things, my view, I'm a family physician, so my view of the medical care system was we've done a fabulous job over the last 50 years of developing a very good acute care system, from the emergency medical services to the emergency room to the ICU to all the interventions that take place as a result of a lot of incredible advances in medicine. What that's left society with is really the burden of care of the future is chronic care. We've done some amazing things with medications and interventions, but now we have a population that's got multiple medical problems, has got on multiple medications, and we don't really have a population of workforce to care for them. There's many long-term studies that would suggest that care of the aging by the subspecialists who are really focusing on the heart or the liver or the pancreas or whatever it might be, that are organ-based or systems-based, that care is not the best care. And we have moved our entire system to, creating a lot of subspecialty shops that are doing great work. But I think many experiments out there are demonstrating that unless you have a really strong primary care base to take care of these people, and we know that as a family physician, I know we'll never train enough family docs in the next 20 years to actually do this. So working in healthcare teams, working with physician's assistants, working with nurse practitioners, I think is really the only way to go. We certainly appreciate all the support that you've given in trying to increase the number of graduate medical education or residency slots. The tendency is, however, for most hospitals when they're building new residency programs to build residency programs that make money for those hospitals. So they tend to build fellowship slots in cardiology and gastroenterology, as opposed to primary care slots in internal medicine, family medicine, and geriatrics. I really think we need to focus on, if you're going to do anything about graduate medical education and residency training, we need to make sure that those dollars go to the right places, that we build the workforce to do what we need to do to take care of this population as they age. That chronic disease model of taking care of people with multiple medical problems and multiple medications is really one of the focuses of our medical school. We're one of the few medical schools that has a required geriatrics rotation. We actually have medical students spend time in nursing homes. We do the type of things that we really want to do to what Ken calls geriatricizing our curriculum a little bit, to understand what it takes to actually care for people with multiple medical problems, to have the patient be the focus of that. So my plea is to continue to focus on the workforce. We've focused too much in the last 50 years on the subspecialty side of care. We really need to focus on the primary care, because those patients don't know where to go. Don't know where to go when they have a medical problem. So what are they going to? Well, they're going back to the emergency room. They're being re-hospitalized and readmitted and all the things that we do know, increases incredibly the cost of medical care in this country. A good foundational primary care system is really critical to the future.
Well, what you just said was one of the things we tried to do in the healthcare bill.
Yes, sir.
So are you telling me that's not being implemented?
We haven't seen it happen very much. We realize the federal government doesn't have a whole lot of money to spread around to new GME slots. Florida was able to get over 300 new residency slots that you helped to redistribute. So we hope that they're going in the right direction. Tallahassee Memorial in this community is starting an internal medicine residency to do exactly what we're trying to do. Many of the hospitals around the state are doing this. It's not uncommon when the new rules come out that they're so restrictive in terms of how we're going to apply it, that if you almost don't have a program in place to jump out and start the next month, it makes it difficult for you to apply for the dollars. So we need some flexibility to build programs over time. We're petitioning at the state level, at the local community level, and at the hospital level to build residencies around the state so we'll have the workforce of the future.
Doctor, you're talking about two different things. You're talking about GMEs, graduate medical education.
Yes, sir.
It's talking about slots. And we're also talking about the emphasis on primary care and ultimately making that more attractive for students to go into primary care by raising the amount that they are compensated from Medicare.
And that is happening. Yeah, I appreciate that.
That should be happening. Therefore, there's more financial incentive for medical students to go into primary care. Now, with regard to the graduate medical education, Florida is way behind the 8 ball, along with Nevada, because when all of that was frozen in the late 90s, that money that comes from Medicare, that's the source of funding for this GME. Of course, the big growth states like Florida and Nevada were the ones that were penalized. And from the dean's perspective in medical school, from indeed our perspective as Floridians, we're educating the doctors, and then they go to some other state to get their residencies, and they usually find that the doctors stay in those states where they did their residency. So if we can get more of those residential slots, that was an amendment that I added to the healthcare bill in the Finance Committee. But we didn't make up all the difference because I had to deal with 49 other senators. I had to deal with 99 other senators. But we ended up getting something like 350 additional slots. The truth is we're behind the 8 ball since 1998, having been frozen of about 1,200 of those slots. As I understand it, Dean, hospitals and so forth are putting in their money, skin into the game to help make up some of the difference on these residency slots. Is that true?
little bit remains to be seen. Most of the expansion of residency positions since 1997, the Balanced Budget Act, have really been in fellowship positions, not a lot of increase in primary care physicians. I think a lot of hospitals right now are kind of hunkering down, kind of wondering, how they're going to get paid under the Affordable Care Act, what that's going to mean to them in terms of, increase, decrease, remains the same. GME seems to be an area that the federal government continues to look at as far as potential cuts. And so I think, my conversations with CEOs around the state is they're a little bit nervous about putting that skin in the game until they have a better sense of how things are going. I think this reflects the fact that Florida is a young state in terms of its population growth, and most of the hospitals in the state established themselves to really support the migrant population that came down every winter. And so you have big hospitals like Sarasota Memorial that are 800-bed hospitals with no medical education programs there, no graduate medical education programs there. We're working with these hospitals around the state to begin to think about how to do that. The good news is that the rules are that if you're a new hospital that has no history of graduate medical education, you can apply for positions. But you have to basically fund them for 3 to 5 years until you can actually ask for CMS to help you pay for them. So it's an expensive proposition. I think they're a little leery right now until they know what their budgets are going to be.
At the same time, those 800 beds are probably 70% older people.
That's correct.
And that's true of almost every major hospital you'd go into in this state. So, you've got an advantage being from the state of Florida, because you can say to your colleagues, we'll volunteer to be the test bed for some of this stuff if you'll provide the money, and then maybe we can see we go. The other thing that strikes me as somewhat ironic is that we're sitting here in 2013, there is no agreed upon definition yet of what an older person is. Now, Social Security eligibility has one line. Medicare eligibility has another line. If you ask people at AARP what an older person is, they'll tell you anybody over 50. But, what is it? And so if you're the Senate Aging Committee, which population are you looking at, and how are you supposed to do what you're doing when nobody agrees what that population is?
Senator.
Yes, sir. Dan?
What you're hearing around the table and for the rest of this session, and what you will hear a lot more of as chairman of the Senate Aging Committee, all stems from the same fact. We have a larger percentage of our population than we've ever had before, living beyond age 65, many of them beyond age 85. This is brand new in human experience, certainly new for the U.S. The Japanese a little bit ahead of us, but we've never experienced anything like this before. And as you've heard around the table, we're still on a very steep learning curve trying to come to grips with what is aging, what are older people, what are their needs, how do we move from acute care to chronic care. And if there was one thing that Claude Pepper always valued, it was knowledge, information, science. How can we use our rational capabilities to deal with the problems ahead of us? And one thing that Claude Pepper did is to really launch with Florence Mahoney, whose husband was editor of the Miami Herald, and with Mary Lasker. They really set the National Institutes of Health in motion. Beginning in 1937, they created a National Cancer Institute, heart, lung, and blood. Disease by disease, they built what is today the world's envy of a biomedical and behavioral research enterprise. And in the mid-1970s, they created a National Institute on Aging, which is now housed in the Claude Pepper building at the NIH. But they did it disease by disease, and an organ by organ system of kind of looking at what goes wrong with people and not at what is driving all of these diseases, which is the underlying mechanisms, the biological mechanisms of aging itself. And now, just within the last year, NIH has now created a research institute that spans all of the other institutes and studies what is now being called geroscience, the science of aging itself, and how does aging linked to heart disease and diabetes and vision loss and Alzheimer's and cancer and all of the rest. This has not really been looked at. The public's not aware of it, but there are fabulous things coming out of the NIH that are getting at the mechanisms of aging, and I would encourage you to take a close look at that as chairman.
That's an excellent point, and we will do that.
Senator
Yes,
Nelson.
ma'am.
I'd like to talk to you about a more immediate issue. When you brought to our attention the study by 16 universities to look at quality of life for older people, we are very sensitive at AARP. We thank you for your vote to avoid the fiscal cliff, which would have been a nightmare with all the implications that it had. But the truth of the matter is that our biggest concern right now, our immediate request of you, is to be very careful as Congress thinks about how to tweak Social Security. Across the country, older Americans survive on an average annual benefit about $18,000. In Florida, it's $14,000, Senator. And that means that our older Floridians are living on about $1,100 a month, which is not a lot of money when you have to pay for medicine, when you have to pay for your living expenses. Our concern with the current proposal is that the changed CPI, we know that the CPI as it exists right now is based on the basket of goods that workers spend in durable goods and so forth. That is not reflective of what elders spend on. So it's already a flawed formula to begin with. The changed CPI ties in the assumption that you will buy one thing instead of another, a substitution type of rate. Instead of steak, you might buy bologna. Don't buy bologna, Senator. My concern is that older Floridians have already made all the choices and have budgeted to live within their means as much as possible. They don't have anywhere else more to go. And if this should go into effect, just know that it is not a minor tweak, it's a major change. We anticipate that the oldest people that are Social Security recipients will be hit the hardest. We have calculated at AARP that a 92-year-old with a $14,000 income a year will receive the equivalent of $1,100 checks and not 12 if this goes into effect. The poorest people will be hit the hardest because they have less to begin with. Women will be hit disproportionately more because they live longer, and they also haven't contributed to Social Security as many quarters as the male counterpart. And then finally, it's going to hit our veterans and our disabled Americans. And when people are just living and that Social Security check is supporting as their only source of income, we cannot afford to make those changes. We need to have a broader discussion on more responsible choices in tweaking Social Security. So when that vote comes up, Senator, if you could please oppose it. It's not good formulaic for Floridians, and it would be, we have currently at AARP, we have the support of 34 other organizations that represent women and veterans groups who have agreed that this is not the way to go.
Is there a basket of goods that more correctly reflects senior citizens that would be the calculation for the cost of living index as it
Absolutely.
would apply to seniors?
Yes, sir. Yes, sir. It's known as a CPIE, and I believe that Representative Deutsch has led some conversation on that in the House. But that is really something that we need to look at to be able to really bring in line those cost of living adjustments to be on par with what seniors are really spending on, the larger proportion on medicines and health care overall.
Is the CPIE compared to the change CPI compared to today's CPI? Is the CPIE, is it a higher percentage?
Yes, sir.
Yeah, Senator, the E really currently stands for experimental.
Correct.
But it's an experimental CPI reassessment for the elderly. And according to that reassessment, and I think it was done by the CBO, but I could be mistaken, the percentage of people over 65 who are in poverty rose to 15.9% from about 9.8%, mainly because of the impact of out-of-pocket medical expenses.
I would just like to add to that, that I think,
But presumably that would change as the Part D of Medicare, prescription
Closes-
drug benefit,
closes with the ACA.
kicks in.
Yes.
So as that's fully phased in by 2020, that would have an effect on this CPIE.
It would reduce the out-of-pocket healthcare costs.
Okay. Yes, ma'am. Jill?
I was just like to comment on the importance of this issue for the future of Social Security recipients, because the retirement income system in the private sector is really perilous. I feel like we haven't paid enough attention in terms of what's happening from the switch to the defined benefit plans to defined contribution plans. And I know our governor wants to do that with the Florida retirement system, eliminate the new entrance to the defined benefit plans. But this is a wave that's happening all over the country in the private sector and in other states, and I think it's probably inevitable for the future. But that's putting all the burden then for people on what they have saved during their lifetime through their IRAs or 401ks, and it's going to make Social Security so much more important a source of income in the future. I just read a recent article that the average person in their 50s has less than $25,000 saved, and they're in their 50s. I don't even know how they're going to ever be able to retire on what they've got. And higher divorce rates have exacerbated that problem because people often have to cash them out when they get divorced and split it, take the tax penalty. They lose their job in the recent recession. They've drained their retirement savings, paid the tax penalty, and some have nothing left. So, I think especially because of the recession for people in their 50s and 60s now, this is a really critical issue that places more emphasis on the importance of something like Social Security that is guaranteed.
It's interesting that the state of Florida, as articulated by the governor, is asking that its Medicaid delivery be done by insurance companies, HMOs, where in fact over the last several years the experiment called a pilot done in 5 counties, 2 urban and 3 rural, has not been successful. And yet the governor wants HHS to approve the additional 62 counties. I'm assuming that HHS is not going to approve this expansion unless there are safeguards put in on the quality, which has been shown in the pilot study, that without those quality requirements, then you're just not getting the health care that you need. And so this figures into this whole situation as well.
It does. One of the problems, I think, is that HMOs traditionally depend upon a large cadre of fairly healthy people to support their business. And with that extra money not spent on them, they can support the people who need more care. Unfortunately, that's sort of the way Medicare is designed too. And with most older people being fairly healthy, they're not very expensive, but there's a small percentage of 3 to 5% who are incredibly expensive and who will die in 2 to 4 years, regardless of the quality of medical care that they get, because they have very serious illnesses which we can't cure. And those kinds of patients need a fundamentally different system than the 60, 70, 80% of healthy and the 20% living happily with a chronic illness. And that's where we really need, and I don't think the Affordable Care Act actually deals specifically with them, although potentially CMMI could direct certain ACOs or comprehensive primary care groups to focus on those people. We know that PACE, for instance, works, but it's hard to scale up. We know that hospice done correctly works, but it's focused on just a small part of that person's life. And really what we need in Medicare is a system that focuses on that 3 to 5% that have what Joanne Lynn calls eventually fatal chronic conditions, and say, how can we provide them with the best possible life? And that's going to have to be through a team-oriented provision. I don't think most HMOs are capable of delivering that kind of care. There are a few that have demonstrated that possibility in the country, and they could be used as models, but I'm very worried about this Medicaid expansion and its resulting cost to Medicare because of poor management. And I wanted to say one last thing about that, and that is, I hope that we will have the wherewithal to deal with the very end of that, which is advanced care planning, because a key thing in all of these types of coordinated care systems is that they do close advanced care planning with the client so that their wishes, their goals can be met. And almost always that results in a happier life and a longer life. So, and reduce costs. So I think we really need to get over the worries about that and grapple with it directly.
By the way, just so you know, one of the casualties already in the health care bill is long-term care insurance.
Right.
And
It's off the table.
that was basically given up
Right.
in the most recent round of negotiations because of the perceived expense of that. All right, I want to get other people who hadn't had a chance to talk. Yes, ma'am.
I'd like to respond to your very insightful comment about the Medicaid managed care. You probably know that HHS has approved the long-term care implementation as of about 2 weeks ago. And Orlando will be starting that. In fact, I was there last week and was told that clients of services such as Alzheimer's are already being transitioned into the managed care organizations in late May, although implementation is later. This speaks very directly to Florida's aging network. And what I wanted to mention in particular, but it ties back to your point, is the Older Americans Act and the reauthorization. Florida has about 85,000 people receiving services under the Older Americans Act. We have about just under $100 million in services going there now. Average age is 80. 38% of those people are incontinent. 69% are women. Only 24% have caregivers. So these are older people, frail, multiple problems, living alone. Those programs are so cost effective because they use volunteers, they are nonprofit organizations. People like Bentley formed this whole Florida aging network in the 70s and 80s. What we did, Senator, which seemed wise at the time and in today's reality may not be, is we used the Older Americans Act as the framework, the backbone of our whole long-term care community-based delivery system. So when Bob Graham, as Florida Senator, State Senator, created community care for the elderly, we linked it to Older Americans Act. So things like reauthorization are absolutely critical to the almost 1 million people who are getting services every day in this state. And if the Older Americans Act is not protected, reauthorized, and funded, the whole community-based system will be at risk. Now, that system is currently at risk anyway because of the Medicaid managed care decisions of our legislature and governor. But it will be even more so. And what will we lose? We will lose about 100,000 volunteers because they're not going to volunteer for a for-profit insurance company. We will lose $10 million a year in United Way and local contributions from donors, and we will lose the ability for older people to stay in their homes. Let me just say one more thing quickly. Sequestration probably would be 9% impact on the Older Americans Act because of the 7 months remaining. We've done 2 or 3 models in our office, and I cannot stand behind these because we didn't have time or resources to do them well. We project that it would really have a 12 to 14% impact on Older Americans Act because they use volunteers and other things to pay for those services. And the Older Americans Act money goes directly to buy food and other essential services for older adults. Thank you.
Let me tell you what you can do.
Tell me.
There are a bunch of elected members of Congress in this state that are prepared to vote to let sequestration go into effect. What you can do is obvious.
Right.
Tell them what you have just said, as well as the necessity of the reauthorization of the Older Americans Act and how the two tie in. That would be very helpful to
But I
me.
would like to have-
And if your counterparts in other states can start delivering this. You know, I never thought we'd be in a position where it became a debatable item, was the United States government going to pay its bills? But in fact, you've seen what has happened. I mean, these are different times, and these are folks that have a different kind of approach to government. And they need to understand the impacts and the nuances that you have mentioned. I want to give folks who have not had a chance to talk.
Senator?
Yes, ma'am.
Thank you. And thank you for today. I really appreciate this opportunity. You're hearing some very important issues, and they're all very, very important. When older adults are feeling the impact financially, particularly most recently because of the recession, it's the Aging Network that's getting those calls. The Aging Network being the local provider agencies and the area agencies on aging and aging and disability resource centers. We talk about capacity building in the system on the acute care side, but there also needs to be capacity building on the long-term support and services side. The partnership that has to take place between the home and community-based services that is the Aging Network that's outlined in the Older Americans Act and the acute care. The acute care and the capacity building there is very important and valuable and necessary. But it's the Aging Network in the community that is helping to provide the support services that is often delaying and preventing those hospital readmissions and unnecessary nursing home institutionalization. The Older Americans Act, and we need to fight for that reauthorization and to delay the sequestration, because the impact will be very frightening if it doesn't take place. In the Older Americans Act reauthorization, it talks about the long-term care support services that are offered by the Aging Network. Again, the providers and the area agencies on aging, the wellness and the disease prevention activities that take place, the role that we play in long-term care, including managed care and other things, as well as elder rights. It needs to be authorized and it needs to be funded at appropriate levels, especially considering the population growth in this cohort. So, thank you.
Tom?
Thank you, Senator. First, let me say on behalf of everyone at the Pepper Foundation and the Pepper Center how honored we are that you are here. I can say from personal experience that Claude Pepper greatly respected you as a legislator, but probably even more so was extremely fond of you and your wonderful wife. And I know that the times that he got to spend together with you, he would talk about the next day in the office. But moving on, you become chairman at a very critical time. If Claude Pepper were chairman of an aging committee today, he would of course be concerned, but he would be geared up. He would be fired up for this fight, because looking at sequestration and cuts, he felt fundamentally, almost in a religious way, that the government had a responsibility to take care of everyone, and in particularly people who were not in a position to take care of themselves. And so it was a fight that he enjoyed, and again, it was almost spiritual. And so we know that you will do that. On the long-term care front, let me say, because this sort of dovetails with what you said about his giving up the Aging Committee to become chairman of the Rules Committee. You may remember, because you were there then, that one of the last things he did in his career and in his life was to push through a long-term care benefit vote on the floor of the House. And it was almost quixotic because he had sort of the old bulls, the Dan Rostenkowskis and the John Dingles and the other chairman of these important committees sort of opposing him on this issue, more for sort of procedural reasons, but nevertheless. And he lost that vote, but he wasn't that disappointed. He was, you know, in his mind, he was 88. He thought he would be living forever. He never looked at a time when he wouldn't be there. And I think that's in part what kept him going, was the fact that he looked forward to the next day and to the next fight. But in that debate, he said something which he said often, and I think he was very proud of. And he talked about the times when his mother would say to him that she didn't want to be supported into a nursing home, and he very proudly said that he took care of her and he kept her in a home. Now, not everyone can afford to do that. Not everyone has the means to do that. And so, in large part, I think that was part of this sort of spiritual reason that he felt that we all owed something to those people who came before us. And so he fought, he would have continued to fight had he lived longer. You now have an opportunity to do that. And I think all the wonderful things that we've heard today and important things can hopefully inform you. And I think that we can all say that we're all here to help you and to give you whatever information, guidance, and support that we can sort of moving forward so that you can carry on Claude Pepper's legacy.
Thank you. Yes, ma'am.
Thank you. I'm happy to be here and have an opportunity to speak. I work with the state agency, the Department of Elder Affairs, and work so closely with the network, the Aging Network. You've heard from a few people to talk about home and community-based services. One thing that the Department of Elder Affairs prides itself on, and I've been working with the department now and in an aging field for more than 20 years, but we really do want to support families and elders and help people to be able to stay in their homes and communities. The Older Americans Act is quite significant in that process in terms of providing on the continuum of care that we have for our elders. We have people that aren't ready for nursing home. They aren't necessarily ready for assisted living. They need support to do their shopping. They need support to do their cleaning and help them in their homes. And that's what the Older American Act program does. One thing that's been very significant too, that has come to the attention of, at least to my attention, is that Florida is one of 10 states that has a huge number of elderly people that are hungry. Mm-hmm. And that to me is huge. We have the area agencies on aging do what we call an area plan. It's based on the state plan. It's what the department does. And part of that plan is just determining how you're going to utilize resources, whether they're publicly funded resources or resources in the community that benefit the communities. And we do what we call targeting. And the Older Americans Act requires that because that act really wants to support people that are low income, that are isolated, socially isolated, and don't have the wherewithal to provide for themselves. So that is a focus I think that Florida needs to have. We're trying to figure out how to work more closely with some of the nutrition programs that are funded through the Older Americans Act to try and more fully address the hunger issue. In the Older Americans Act, there's the Title III, what we call 3 C's, for congregate meals and home-delivered meals. That is a huge, huge benefit and resource to elders in the state of Florida. One more thing, we have been provided through the Florida legislature. The department has the Alzheimer's disease. I've been talking to some people earlier this morning, the Purple Ribbon Task Force. But I see this as an opportunity for Florida because we don't have a state plan on Alzheimer's disease. At the national level, there is a state plan, national plan now to address Alzheimer's disease, but we have an 18-member task force. 6 members were appointed by the governor, 6 members were appointed by the Senate, and 6 members by the House. And the Department of Elder Affairs has the luxury of providing the support to that task force, but the task force submitted an interim study January the 30th, where it did an inventory of services and supports to families in the state of Florida to determine what Florida's doing regarding Alzheimer's disease. And it will provide, the task force by August of this year, provide recommendations with timeframes for implementation, and which will will be the baseline for the state plan. So I think that this is huge because we have so many people that are impacted by Alzheimer's disease, and with people living longer, we just have more people impacted by it. And we have a lot of caregivers who are spouses, children, and other folks that are trying to take care of people with Alzheimer's disease. So we really do want to, as a state, work harder to define our efforts in regard to supporting people with Alzheimer's disease or impacted by that disease.
An offshoot of this question of hunger, different cities and local governments utilize community development block grants in different ways. And for example, the city of Miami uses the CDBGs, 15% of them, for feeding the elderly. They want to change the formula so that they could use up to 25% for feeding the elderly. What's happening in Congress? You see exactly the opposite trend.
They're going to block.
You see CDBGs being cut, and particularly if sequestration were to go into effect. So we have not just a problem with regard to the elderly, we have a problem of a crisis of government that is approaching us.
Senator Nelson, I believe that the Washington Post came out with a story within the last couple of weeks that those that are elderly in the United States now face a level of retirement that is lower than their own parents and grandparents. That's unheard of.
Yes. I want to get these two gentlemen before we adjourn.
Sure. Thanks, Senator. I just wanted to bring up a couple of other things you may be interested in. I know another interest of yours is the financial fraud with the elderly. And the CFO of Florida, Jeff Atwater, he's starting an initiative on this. It's going to be launched in May, and it's Operation Safe Stop Adult Financial Exploitation. And so it'll cover 3 different topics, and they're going to push it out as part of Older Americans Month. And that'll be a system of workshops in 16 different cities. And we were contacted by them to help with that, and the university's trying to contribute. But it made me think of another program that the Pepper Institute is involved in with federal highway safety money. We participate with the Florida Department of Transportation on a Safe Mobility for Life coalition. And it's a group of members from state agencies and organizations that's trying to keep elders and older adults safe and mobile as long as they can. And I just think it's a really good model. It uses a little bit of money to push out a lot of information so that seniors can be informed about the driving issues that older Americans face, but also events like CARFIT events and refresher courses. It encourages them to be proactive about all that, to talk to their physicians. We found in a survey of older adults in Florida that fewer than 5% had talked to their physicians about their ability to drive. So that older adults in Florida can develop a retirement plan and be proactive about their driving. I know that's not exactly the topic of today, but I feel like it's been a real successful model in pushing out information and getting a broad coalition that can have a lot of perspectives on it.
Thank you. David?
My comments build on John's in the sense it's about pushing out information. My guess is that economic literacy among the elderly is quite poor. At Florida State University, about 60% of the undergraduates never have a course in economics. And to address this issue, the Stavros Center for Economic Education here on campus has put together a course we call Common Sense Economics for Life. And it really is designed to not prepare you for any other economics class, just prepare you for life. And about a quarter of it is about personal finance. And we have a number of people who are very interested in getting this driven out nationally. We've got online programs, courses for it, a lot of video clips, a lot of lively stuff to make it fun and informative. Some people have come to talk to us about the wisdom of having this for the elderly in terms of their financial planning. And it really suggests that the definition of elderly should be about 50 for this, or younger, in the sense that we can really increase their literacy, in some sense better prepare them for what's going to be coming along financially. And I suspect it would need some tweaking that could also be used to help address the fraud issue. So I think that's an issue that our college is doing something to help, which I think is probably an important problem for financial planning in the future.
Any other comments? Larry?
Senator, just to follow on a couple of the comments been made earlier by Jill and others. Jill mentioned private long-term care insurance and some of the uncertainty that people are encountering as they try to use it. Those who have, the minority who have plans, are finding that often they're surprised by the nature of the coverage, that it's not as extensive as maybe they had anticipated. I think that private long-term care insurance has an important role to play as we look at the future of funding for long-term care. I don't think it's going to become a majority funding source, but I think it could be a 20% kind of coverage down the road. But I think it's important to have national standards for private long-term care insurance to help inform the public and to avoid the kind of surprises that Jill was talking about. And I know this has been an issue that Congress has brought up from time to time. And I know it's an area where you have extraordinary expertise, given your history in Florida in insurance. I think it's something that really needs to be looked at very seriously. I think it would help the industry. I think it would help restore trust and make them a more viable player in the financing of long-term care in the future. And they really need to be. Two, in terms of the model that Bentley was talking about, that is the absence of a long-term care model, I think that, I know what he's talking about in large measure is true, but on the other hand, as people have talked about it, from Margaret Lynn to Linda and others, the aging network over a 35-year period has built the home and community-based long-term care system in this country, the alternatives to nursing home care, in one state after another, including Florida. That is, in fact, a model. And it's one, in fact, that I remember talking to Senator Graham back in the summer of 2001. And at that point, he told me that he was planning to push legislation to add home and community-based services as a benefit under Medicare because of the extraordinary success of this program through the agent network across the country, especially in Florida, where he had done some of the pioneering work with community care, home care for the elderly back in the 70s. Then, of course, we had 9/11, and we had the Part D that came along, and then the fiscal crisis. But that's an indication, going back some time, that a lot of folks, including colleagues of yours and close friends, who have felt that we did have a model for long-term care system in this country emanating from the aging network in the form of home and community-based services. So, and in terms of aging and research, I have felt for a long time that we do not put enough money into dementia research. It's about $462 million. That's a fraction of what we put into AIDS. And I'm not saying we should reduce the research on AIDS, but it's about 20% of what we're putting into research in that area. It needs to be much higher, especially given what's coming. We're projected to have 15 to 17 million people with Alzheimer's over the next 30 years. The cost is going to be in the many billions, and the reduction in quality of life is tragic. We need much more investment in this area.
Can I add a footnote to that? One of the things that stood my hair on end when I was the Secretary of Aging in Florida was, if you look at just two counties, Charlotte and Sarasota, where roughly 50% of the population is over the age of 60 now. That means 20 years down the road, unless those people die, and we're keeping more and more of them alive, as has been pointed out by the medical people here, there's a very good chance that we're going to wind up being first in the United States to have an entire county with over 50% of its population being faced with Alzheimer's disease. That's never happened before. We don't know what that would portend in terms of demands on the healthcare system, on the long-term care system, if there was one, and a whole host of other issues. So when I agree with you, we need to get Margaret Lynn and Linda to get these local folks to talk to their elected representatives in the House, who are the most liberal people we're dealing with right now. But in the meantime, there are some other sleeper issues that are going to ambush you. One is, we're out of nurses right now in the state of Florida. And that's not going to improve in the short haul, and I don't know how you fix the problem. I mean, we've raided all the third world countries we can to take their nurses and bring them over here, which that's the way the world works. But we need to be training more, and we're not doing it. That's one piece of it. They already are saying that when the Affordable Care Act goes into being next year, we're going to see a 50% increase in demand on the system. Our colleagues at the med school have said, we're not training the doctors. We know we got to train, nurses. So how are we going to look at the confluence of all these things taking place? And my concern is that you and Diane are going to have to answer about, why didn't you come up with a solution to this before it ever happened? So just be aware that there's some landmines in the road out there.
A lot of landmines. Now, when the health insurance exchanges are established, and by the way, it looks like that the federal government will set it up for the state of Florida, since our state has refused to do it, that there is going to be more of a demand because more people will be insured, and assuming that Medicaid is going to be expanded. The question is a million people in Florida going to have that opportunity of health care with the expansion of Medicaid, which is basically paid for by the federal government? Over the course of the next 10 years, Florida's contribution would be about 5, maybe over 20 years. Florida's contribution is about $5 billion. The federal government's contribution is in excess of $60 billion. That, starting next year, would expand Medicaid coverage for 1 million poor and disabled people in Florida that do not have health care coverage today. Now, that one seems pretty simple to me, if you want to give health care to 1 million people. But apparently, in the councils of the state government, that is an anathema to them. Even though the federal government is paying 100% of the cost for the next 3 years, and the max that the state would ever pay would be 10% of the cost after the year 2020. So are Florida tax dollars going to fund the expansion of Medicaid in all the other states, but not in our state? So that just put that in the stew and stir it around. This study in 8 universities around the country that's being done not only on a sedentary lifestyle, but also obesity. And how does that affect the health problems as you get on into the aging process? Hopefully we'll get some results from this study. I wish I had some answers here for you, but I don't. That's why I came to you, to get you all to give information to Kim and to me as we approach some of these decisions that are going to be made and about what we should do going forward. I can tell you, I do not see the answer for long-term care insurance. It would be great if we could have it, but in this environment, how in the world are you going to get it through politically when we had to fight as hard as we did to get it into the health care bill, and now because of the cost of it, it's gotten axed out. So we've got a long way to go. But as Tom says, the example set for us by Claude to fight for the least privileged and the vulnerable among us. And I can't help but look at that statue over there, the fella, not an elder, but on crutches. And that's part of the kind of folks that we're trying to help. So, thank you. Now, you know where I'm going next? I'm going to visit with the legislative leadership. So I will carry some of these ideas, but before I go, I want to have the opportunity to go around and see some of these exhibits and to think back onto those old days with Claude, and to thank Florida State for doing this kind of center. Increasingly, programs in gerontology are getting focus. As our population ages, it's most appropriate, but we got a long way to go. Remember this, that a society always has a responsibility to take care of the very young and the very old. And so it's in that spirit that we gather today, and I thank you very, very much. Have a good day.